Our next speaker is Diane Cummins, who is the Special Advisor to the Governor on state county realignment issues. Diane is just truly an expert in this area. I've had the privilege of working with her on a couple of different classes where we've been sharing some history, and her knowledge of the history of California is more than any living human, I'm sure. It's just amazing. I keep asking Diane to please write a book because she knows so much about what's happened in every major issue that's happened in this state over the last probably 30 years, I'm guessing, at least 30, 35 years, wow. And she's been not just in the external negotiations that everybody saw, but she was also in those back rooms where the real decisions got made. So she's really got an incredible knowledge of everything related to finance and policy in the state of California. I first met her, she was working in the Department of Finance, and we worked together on the 1991 realignment. And that's when I first found that Diane's just absolutely wonderful to work with. She's going to talk with us today a little bit about what's going on currently, and there is a lot, in case you hadn't noticed, at the state level, and particularly around what some of the governor's intentions are over the next few years. So, Diane.
Thank you very much. At least she didn't say decades and decades. That's what people usually say to imply that I'm old. Well, good afternoon and happy Valentine's Day. A lot of people wearing red. Pat, very nice. I saw a lot of people wearing red today. It's a pleasure to see you all again this year. It's really opportunities like this that allow us to hear from those of you working at the direct service level, and I think I speak for the entire administration, but particularly myself, that's really important to us because we actually don't know what goes on a day-to-day basis. So hearing your questions, hearing your concerns is truly important. I want to touch on three topics: the governor's budget, an update on 2011 realignment, and a little bit about healthcare reform. So the governor's budget, I'm sure you know, came out. It's balanced. There was actually some money this year, so we are not in cutting mode, which is a relief to most of us in the budget world. And in fact, people have forgotten how to act when they're not cutting. It's just a very different feeling. The budget has a different feel, and people say, well, what do we talk about now? And, well, let's talk about issues that we can resolve. A lot of people have been coming to the Department of Finance saying, we read in the paper there's $5 billion extra in the state, and we have these ideas to spend it. I can't tell you the number of people who drop by and ask. And let me assure you, before you get too excited, the Department of Finance, noted optimists, of course, do not believe that there's $5 billion. This is probably a cash issue for two reasons. Because of Prop 30, people have probably accelerated their payments for 2012 tax liabilities, and because of the federal tax concerns, people accelerated their income into 2012. So we're seeing a cash flow. We do not think that at the moment that it's ongoing revenue for the state, and so no one knows. We won't know until May revision. So May revision this year will be extremely important. Not that it's not important every year, but this year, because of this anomaly in the cash, I think it will be particularly important. It's also important to remember that the Prop 30 tax increase is temporary. So the governor's view of having a balanced budget and paying down debt is particularly important, because if you don't pay down debt, then when those temporary taxes go out, you're still going to have an imbalance. So that is his priority. And the budget, while it's balanced with $1 billion reserve, has risk. every budget has risks. This one has, Proposition 98, the revenue estimate itself, the economy, which no longer is just the state economy, it's the national economy and the world economy are risks to California. And our caseload increases, and yes, the implementation of healthcare reform is a risk. So there are plenty of concerns and risks and issues around the budget still. The governor's commitment, as I said, is to a balanced budget into the future, pay down debt. He's a perfect fit with the Department of Finance and the natural tendency of the Department of Finance to say, no, we don't want to spend any money. And that he may sometimes feel that a little more than we do. So budget, not bad, looking better than it has. 2011 realignment. Well, if revenues were good, then one of the good things about 2011 realignment is revenue is healthy. The sales tax revenue is healthy for 2011 realignment. I think our first and foremost commitment in 2011 realignment is to continue to work closely with counties and stakeholders. There are continuing issues with implementation, things that people didn't think about, changes that may be needed. So if you have those, please let people know, because we do talk about realignment. We have meetings every week to talk about what are the issues that we see and what do we need to do. The best news possible in realignment is that Proposition 30 passed and constitutionally guaranteed the money for 2011 realignment. So that money is constitutionally protected, can't be taken away unless programs are actually reduced, so it can't be taken away from the counties for 2011 realignment. I said the sales tax revenue is healthy. It's $5.5 billion in 2012-13, $5.9 billion in 13-14, and by 2014-15, it's about $6.4 billion, current estimates. That means there will be program growth. And for the behavioral health account within realignment, the growth is estimated at $24.8 million for 2012-13, a little over $73 million for 2013-14, and almost $200 million for 2014-15. And it grows significantly starting in that year because the way the formula works, Child Welfare Services gets some first call on restoration of a couple $100 million. And after that, there's more growth to be distributed. This is our estimate now. That estimate will change in May. And then in September of each year, the growth allocation will be sent out. The growth in EPSDT and drug Medi-Cal do not add to the base at this point in time. They are one-time allocations. That was actually a commitment we made because we don't know if we know enough about where the caseload is. If we have dollars in the right place, we want to make sure that they're in the right place. And so we didn't set a base. Most of the programs in realignment have a base allocation, have a statutory formula for growth. That is not true in EPSDT and drug Medi-Cal. So it's something that people will have to work on. There has been a significant amount of reallocation of funds from one county to another in the past, and until we get that settled and a better understanding, I don't think we want to set a permanent base. We have committed to convening a group of stakeholders to talk about what are the factors that should be considered in allocating growth. And we're hoping to, our intent is to begin those conversations soon. The first call on any growth funds is for unfunded entitlement costs in the behavioral health account, so drug Medi-Cal, EPSDT. That's the first call on growth funds. And so, for instance, if there's 24 million in growth funds for 2012-13, if you have 5 million in entitlement costs, then there would only be $19 million for growth. One of the struggles that perhaps you can help us with is, what does it mean to allocate growth in an entitlement program? If you don't have the need for the service, you don't have a call on the dollars, what is the growth for? Should it be at the county? Should it be at the state level for future times when there may be revenue shortfalls or growth exceeds the revenue growth? So there are still a number of questions to work out in those programs. Remember, in EPSDT, we did increase the allocation for a full year's cost of Healthy Families and a full year's cost of KDA based on our best assumptions. So the allocation for 2012-13 is higher by that much more than you would have expected because we added those two program components. We are tracking the claims data, of course, and working with the Mental Health Directors Association and counties. We'll see how close we are in May and what needs to be adjusted. But certainly at the January budget, the allocation appeared more than sufficient to cover the estimated costs. So that is a point to remember. We'll just have to continue to monitor that piece. Within Realignment, the other big program change, of course, was AB 109. And I was going to ask the question if there's anybody here today from law enforcement. Don't everybody raise your hand. This is my new question. I go to the welfare directors, I go places, and I say, well, who's here from law enforcement? When I go to a law enforcement meeting, I say, well, who's here from Health and Human Services? There's never anybody in anybody else's meeting. And I think that's just a little symptomatic of one of the issues we have in AB 109. I certainly hope that at the local level, there's a lot more interaction between the Health and Human Services, behavioral health people, and the law enforcement side of AB 109, probation and the sheriffs. Because the people told us at the beginning of Realignment that it seemed illogical, given healthcare reform, to move behavioral health to the counties. We thought it made a lot of sense. For one thing, counties provide those services, and with an AB 109 allocation and people at the additional people at the local level who clearly need substance use disorder funding and mental health services, the county would now have this money at the local level to integrate services, provide services in a broader context. I don't know how many of you are on the CCP at the local level. I hope some of you are. I think that, it's like everything else. Some law enforcement officials in counties have embraced this change wholeheartedly. Others are completely overwhelmed by the number of people coming back. But all of them, all of the sheriffs, all of probation officers who we talk to say they understand, particularly the sheriffs, they understand that they have to change the way things are done at the county. There is not enough money to build enough jails to lock everyone up, and that certainly was not the intent of Realignment. So you have to start providing services, and you should always remember that the AB 109 formula developed by the Department of Finance had a treatment component. Yes, there was a monitoring and a jail component, but there also was a treatment component. And sometimes people forget that at the county level, and you need to ask questions about that because that money is there and should be prioritized, we think, for treatment. So I hope that you and the sheriff or the jail commander and the probation chief are talking weekly. If you're not, I hope you take the first step and reach out to them and say, It's been 15, 16 months. How's it going? Anything we can do to help? Because really, this was a sort of a life-changing program change for law enforcement. The counties and our law enforcement partners have raised some very significant issues in the mental health world. Medically disordered offenders, none of these issues will be a surprise to you. The ability of sheriffs to house offenders from state hospitals in their jail. Long-term offenders, we have some people in jail now for 15 to 20 years, 30 years. That is a long time to have people in a county jail. And they have significant health and mental health issues and substance use disorder issues. So, they have raised these issues. We hope at the local level they are talking to you and getting your advice on the mental health side. When we try to resolve the issue at the state level, we will certainly be talking to CSAC, to CMHDA, to CADPAC to talk about, do the solutions that we want to come up with make sense? Make sense for these offenders, for the community, for the program in general. So I think that's a very important piece of what's going on. There are entirely too many people, I think, in county jail, state prison, who have mental health problems. We have an opportunity, particularly with healthcare reform, to try and do something about that. And so I just think that talking about it leads to, that discussion leads to solutions, ideas, and that's what we're looking for to try and help solve some of those problems. There is one piece of 2011 realignment that is proposed for change that I'm sure you have heard about, will generate a lot of discussion and probably you're not in favor of, and that is splitting the growth in 1991 realignment between mental health and Calworks. The reason that we did that, that we proposed it, is that after we did the structure of realignment, we did another major initiative, the Coordinated Care Initiative. It's called CCI, the CCI initiative. So that dramatically changes the way the caseload account works in 1991 realignment, because the state has essentially assumed the larger share of cost of the in-home supportive services program, which was the big driver of costs in the social services caseload account, which meant that mental health wasn't getting as much money. So we don't do that for a couple years, but after a couple years, when your base in 1991 realignment will be higher, we made the proposal to split that growth because of the way we changed the social services account. It's a proposal. We want to talk to people about it, but that was our rationale. In terms of health care, what to say about health care? I'll try not to say anything directly opposite of what you've heard today, but that could be easy to do because it's big, it's complicated, there are lots of moving parts, and the state has a particular view of what happens under different options, which perhaps makes it a little more complicated. And of course, on top of that is the fact that the federal government is a little slow in releasing directions and guidance to states. And January 2014 is like next month in terms of implementation. It's not very much time at all for what has to be done. The governor has been very clear. This is like Senator Rubio's reach. If I had a bottle of water here, this would be just like Senator Rubio's response to the State of the Union. The governor has said clearly that he wants to do the optional expansion, but that doing it right is more important to him than doing it quickly. And I think people have a little bit underestimated how complicated this is about deciding, for instance, who's a newly eligible person, who's an old eligible person. How do you make that determination? How do these pieces and the new process really fit together? And so he has put two options on the table, a county option and a state option. Both of them have risks, rewards, positives, negatives, and we're trying to spend our time talking to the counties and all of the affiliates affected within healthcare reform about the different options and what makes most sense. One of the big issues that I think is important to understand from a state perspective is that if the state is to assume the risk of an optional healthcare expansion, then we have to assess the state's ability to continue to allocate money for what was essentially a discretionary state program that was realigned in 1991, and that was funding for indigent health. Doesn't have anything to do with the mental health funding, it's the indigent health piece. Those were two block grants that were discretionary at the state level. We thought it was important in 1991 to preserve those programs and realign them. But if that money is not going to be used for indigent health and the state is going to assume the risk and the cost in a state option, then we have to reevaluate those resources at the local level. It's about $1.5 billion. Now, one of the hardest things to do is actually try and figure out the money at the local level. We used to have a report that actually talked about indigent healthcare costs at the local level. That was eliminated in 2007-08 as a budget reduction in one of our departments. And so we really don't have a lot of statewide information about what the costs are. How much of the 1991 health account is being used for public health, for jail health, for indigent health, how much of it is being used to match already for federal funds. It's very complicated because we don't understand that piece. So we're trying with the counties to get at that piece in a couple different ways and trying to work through that issue. And I think that a really important piece that I will just stipulate that I know very little about, and we are going to, I think the state in general knows very little about, and we are going to be looking to all of you for assistance, is how in a state option or a county option, how does the funding for substance use disorder and mental health work? How do those pieces fit together? What does parity mean? Where does the money come from? Which is one of the reasons I continue to talk about the AB 109 money, because there is money out there that I know is not being matched right now, is not being perhaps used for the programs that it could be used for. We all have our own sense of the numbers and of how these programs may fit together, but I view that as sort of a theoretical understanding. It is not a very practical understanding. So we will be looking to you and your statewide organizations to try and help us figure that out. Now you might say that that's counties working against their own interest, because the more the state knows sometimes, the more dangerous the state can be. But this governor does not feel that way. I mean, he feels very much, and I think we definitely agree with him, that our working on these issues, whether it's AB 109, whether it's continued implementation of 2011 realignment, whether it's healthcare reform, he views this as a partnership. He views counties as the best place to have these services provided. He trusts the counties to do what is right for their community, and that's going to be different, for each of the 58 counties. Makes it a little hard sometimes because people want to know, well, what's the statewide success of AB 109, for instance? We don't have any idea. We view it as a county success. It's what that community wanted. So in some ways, the county option in terms of healthcare reform is a very similar philosophy. It has risks. The state option has risks. But I think that one of the things that this sort of synergy around 2011 realignment, AB 109, and healthcare reform provides us all an opportunity to fix some things, to expand some things, whether it's under LIP or Medicaid or some other program. What do we do at the community level to stop the cycle of people with mental health issues or substance use disorder issues going into jail? I mean, we've had success with other programs. Here's an opportunity with 109 to do that again. Can we do something about early access to Medicaid so as people leave jail, then they have a continuum of services, and they are not sort of decomposing as you walk out of jail because there's nothing available. So that's going to be important. And that wasn't the right word. I saw your face. It's not the right word. Decompensating is the word. Thank you. So my real message regarding healthcare reform is there's so much more to come. And I would just urge you all to be, because you're on the ground and know this, to be creative, think outside the box, reach across to law enforcement, think about other program areas that can be brought together and integrated, and solve some problems and perhaps do some things that people have wanted to do for any number of years but haven't had the opportunity. Sometimes when you do really big things and people are watching the really big things, you get these other little things done. And that's an important lesson that we've learned at the state. Sometimes we can join up with counties to do some of those things, and other people may not even notice, and that's a good thing. So I think with that, I'll stop since I've covered the 3 areas and answer questions. You must have questions. Realignment's working perfectly. Healthcare reform is clear as can be. You think the budget is perfect. All right.
109, hey, that's all working.
And 109's working well. Thank you very much. Yes, sir.
At the local level, we're certainly doing what you suggested, having lots of interaction, working together, trying creative ways. So I believe that even in a conservative county like ours, which had a negative reaction, there really is a recognition that we can have an opportunity to do things better. So I do thank you for your comments on that. I do want to make sure you understand from a county perspective that there's the sort of overt realignment, 109 realignment, and then there's sort of a shadow of that that's really not, people aren't aware of. So a good example of that would be that the parole population has declined about 55%, but the parole outpatient clinic psychiatry access has declined 75%. There are now only 10 psychiatrists statewide for the whole parolee population. And so that's far and above the ratio that you would see. And what that means is there's sort of this unacknowledged impact on the safety net that's underneath the parole safety net. Those people fall into our system in even worse shape when they cannot access their needs. So I just thought I would share that with you because you're probably not going to hear that from someone other than a person at the county level. So thank you.
Actually, that's a very interesting comment, because you're the second person to bring it up today. And the first person was a person from the Department of Corrections. And I think that there is a recognition that there's a problem. And I mean, parole has decreased significantly. We have downsized, or trying to downsize, the Department of Corrections and have the Department of Corrections live within its means. But now there is this continuum that they have to be more aware of, that people coming out of prison go to a community, come back from a community. These services are important, and maybe there's a different role for the parole outpatient clinics. And so if you have ideas about that, I would be very interested in hearing them, because I think you are not alone in that concern and interest.
Diane.
Hi.
Just following up on your AB 109 comments, CMHDA and CADPAC recently just completed a collaborative survey that we sent to all the counties around AB 109 funding for rehab services. And we got 52 responses. It looks like, I don't really have a question here, this is just more information, but it looks like about half the counties, they give somewhere between 6 and 10% of AB 109 funds for either mental health or substance use services, or both. A handful of counties get more than 10% for those services, but there's 7 counties who get no money at all for substance use services out of AB 109, and 10 counties who get no AB 109 funding for mental health services. And some of those I know are fairly large counties, so I can get you that.
Could you get
survey.
me the
Yeah,
survey?
I know
Because
you'd be interested in
I think that would be interesting. One of the things that we struggle with, of course, at the state, because if you actually put into statute a data collection effort, we would have to pay for it. And the thought was that we would prefer to pay for services rather than data collection, but that means we're at a disadvantage. And we have a new board of state and community corrections that is actually charged with collecting information and doing reports on the CCP plans themselves in AB 109. So I think any information that we can get would be most useful.
Okay, thanks.
Thank you. Yeah.
Hi, I'm Tom Traben from Alameda County. About half of what I wanted to say, Tom just said. And so I just want to build on that AB 109 has been a great bellwether for what happens when benefits that typically were constructed and standardized at the state level devolve down to each county to decide for itself. And we're now faced with making some recommendations about a county versus state option for Medicaid, for Medi-Cal. And based on what we've learned from AB 109, when our joint CADPAC-CMHDA Health Reform Committee met to go over what would we like to recommend, I think we reached a fair consensus that when it comes to setting the benefit standards, that it would be best to have the state do that. And when it came to the delivery of services and the quality risks, that should be at the county level. Its care is delivered locally. In the discussion, though, there was, I think, some lack of clarity amongst us about really what distinguishes the county from the state option with regards to the benefit coverage standards, and what distinguishes the two options from each other with regards to local control of services. And that may be too long of a question for you to answer now, but as we move into the public process, I hope there'll be some better definition by the state about what we're being asked to comment on.
And that is one of the things that we are working with CSAC and the affiliates on. What actually does that mean? Because I do agree, I think that's an important component. And the 109 issue, I mean, we have resisted greatly sort of designating that a certain portion of money go to law enforcement for jails, a certain portion go for treatment, portion go to probation because, we think that we gave counties about 65% of our savings. And I think that the first year plans made certain assumptions, and I think that the second and third year and fourth year plans are going to make very different assumptions. One thing we have learned is if you build a cell, someone will fill it. And a county budget doesn't have enough money to do that. And I think that people looking at the entire county budget are going to say, well, wait a minute. I mean, we have to change the way we're doing this. Now, if there are ways through technical assistance that the Board of State and Community Corrections or the administration in general can do things to help that along, I think we would be interested in that. And so I recognize that I think we have generally felt, for instance, in foster care, and we're not having, or Calworks, we wouldn't have counties set grant levels or rates. Those kinds of things are very disruptive to a system. So it gets down to what should the state's role be? What should the state standardize? And then what are the flexibilities for local government?
Hi, thanks
Hi.
for your time this afternoon. As a consumer and as a mental health board member, I am very interested in peer-run services. We heard some really great examples this afternoon on what kind of innovation different counties are doing. There's one problem, though. There's SAMHSA grants, which are going to go away. So I would encourage you and the governor to, as you're developing these plans, to specifically identify peer-run services as a block of money, as a line item, because I think it deserves a line item in somebody's budget. Maybe the counties can run it and tailor the needs, but I think the state and the governor need to make a statement on this.
Thank you.
Diane, good afternoon. I'm Mark Grefowitz. I'm the director of the healthcare agency in Orange County. Let me speak a little bit for my colleagues on the public safety side, because no one raised their hand. Two issues. Every county's different. Sometimes the provision of healthcare services in the jails and the sheriff's budget. In our county, it's in my budget. There is a significant portion of our health realignment that supports the healthcare in jails. So what's the experience been with AB 109? I mean, a year ago I got this promotion. Before that I was on the Community Correctional Partnership. And we're just another big county, and I want you to know that we work well together. If my chief of probation was here, he'd be scratching his head, because I don't know if I'm going to get the bill number right, but in the wisdom of the legislature and the governor, you passed a law a few years ago that allowed probation departments to share in the savings if they came up with innovative programs to keep people from going back to state prison. And that has been slashed in this budget proposal. So my chief of probation would be saying to you, I've got this great responsibility now for providing the community supervision for probationers, and for my AB 109 caseload now, but what about my regular caseload that's there? You've just slashed my budget, and I've got to let go of all these probation officers. So that's one thing that's food for thought. The second thing is, I don't know about anybody else, but we've got our first inmate being evaluated for kidney transplant. The health care costs are going to skyrocket. Year one, you're right, is going to be a little bit different than years 2, 3, and 4 when we have experience. And I just don't know, when you did your computations, if you figured out just exactly what that's going to be. So here's the ask. Because we also run a low-income health plan, we've got about 65,000 members, and we're a good partner with the state. We're doing the billing now for the correctional people. You know, we do that billing for you. We need your help in terms of those people who are awaiting sentencing, who are in the jails, to make that, get that into our state plan so we can draw down Medi-Cal for them, so we can get the federal financial participation. In terms of softening the blow, in terms of the healthcare costs, it's going to be more surgeries, more hospital admissions, more expensive drugs, organ transplants. I know that when you were at CSEC, I also asked for your help about reinsurance for some of the shock claims when you start to have the organ transplants. So that's the ask in terms of, can you help us there? I mean, it was an imperative for your budget to get some help from the federal government for the people that were in the state prisons. That's my ask here, is we need your help to help us all be successful, to get some federal financial participation for those number of inmates who are still awaiting sentencing. The only reason why they're there, either no bail was granted or they couldn't make bail. So I hope that gives you a little bit of sense of, you know, from the criminal justice side, or at least from the health side in this equation. And you're absolutely spot on. Our health realignment is split three ways: our traditional public health services, our support of healthcare services in the jail, and our low-income health plan. And even though I've said this to Diane, even though we're a red cove and a blue sea down there in Orange County, we have a significant amount of overmatch, you know, from the county in our low-income health plan. And so again, that's the ask. I hope that gives you a little bit of sense, if our friends from criminal justice were here, you know, what they might say. So.
Let me just make a couple brief comments. You are not the first person to raise, as it was SB 678 and the probation funding, and you're an important person to ask me about that, but the other person this week who did was the governor. And so we are looking at that issue. We actually made some changes that changed the formula significantly, and I think we are interested in revisiting that issue, even though the theory is under AB 109 that program will greatly diminish and the AB 109 program takes its place. In terms of the healthcare costs, you know, we do recognize that the healthcare realignment money funds a significant amount of jail healthcare, so that we will certainly take that into consideration. And the sheriffs have this as the medical costs is their second item on their list of issues for this year. So it is very significant. Counties really can't begin to afford those kinds of healthcare costs. And so that was the whole idea of the intermediate sanctions, to get people out of the jail. I think when you do healthcare expansion, whichever model it is, they should be eligible for federal funds. And that whole pretrial issue, you know, there are a lot of people, I think there are a couple of bills, there are a lot of people interested in that issue, and there are a lot of interests, varied interests in that issue. So it is something that we are taking a look at.
When Prop 63 was written, it reserved 5% for state administration. A couple of years ago, in a wisdom I don't quite understand yet, that was reduced from 5% to 3.5%. I think it's probably because the State Department of Mental Health was not using all the 5%, so it was rolling back into the general pot. Last year in 1467, the Steinberg bill, a number of new responsibilities sort of passed on to the Oversight Commission, primary of which was evaluation. And I'm very sure that evaluation is a critical issue. Evaluation in most programs takes a percentage point or two or more to do it effectively. The amount that is currently dedicated to evaluation statewide is about $1 million a year, which is not going to get us very far. And we're not going to be able to prove the value of what we've accomplished in California to the rest of the country. As you're aware, Darrell was back in New York with Bloomberg's people earlier this week, and a couple of weeks ago, he and Diane and Sandra Goodwin went to Washington to accost everybody on the virtue of following California's lead. So my concern is that as we look at the adjustments in budgets and things that are going to happen, that we pay some serious attention to restoring the 1.5% that was taken, and look at really doing a competent job of evaluation and having the funds to make that work. I'd love your comments on that.
Anytime there's a budget request, you just have to put together a proposal and forward it to the Health and Human Services Agency and the Department of Finance, and we will take a look at it.
Good afternoon. My name is Scott Grindle. I'm the Health and Human Service Agency Director from Glenn County. And for me, lately, I've been quite disillusioned. I've actually only been a HSA Director since January, even though I've been doing the job for the last 3 years and holding multiple titles, because I really had hoped for what the future would bring, and had convinced my local decision makers that our integrated systems would be critical to preparing ourselves for healthcare reform. And we're not really getting to have much of that discussion right now. And I grew up on 1991 realignment, and that was one of my original visions, was having authority over all three of those pots so that the money could be moved where it was needed the most to meet the needs of my community. And I had similar hopes for 2011 realignment, but I say disillusioned because it's so different than 1991 in that it gets manipulated and moved. And I understand that that's for good reasons, but there are many examples of counties acting together to deal with making sure we're able to move funds to areas where they're needed. And we do that cooperatively amongst ourselves, and not necessarily from a level that is maybe looking at it a different way or not fully see what we see. And I think that, AB 109 is a great example. I'm from a very conservative county. We received an award from CSAC for what we do in AB 109, and I have 5 conservative Republican board members who want to use our jail construction dollars to invest in constructing social services facilities, because our program has a 0 recidivism rate for AB 109ers that enter into it. And that's all about collaboration. You hit the nail on the head for me today when you talked about the relationship. And there's this undefined relationship between counties and the Department of Healthcare Services, for example. And we've started work on a business plan, and we've got a long ways to go. But that relationship is critical to what needs to occur under healthcare reform, which is critical to what's happening in 2011 realignment related to dollars being moved and, in essence, having a negative impact and not necessarily achieving the outcome that was meant to be achieved. And I take EPSDT, for example. There's examples in this fiscal year of us being able to move, having the authority to move dollars to make sure that the allocations are spent appropriately. I could imagine having that controlled from a different location and actually being induced to spend more because we'd be concerned that it would be taken away and used for something different. And we've got to get to a point where we have that partnership to be able to understand both of those perspectives, but more importantly, make them work well. And so I'll end with where I started, which is I'm disillusioned because I had high expectations, and they're not even close to being met. So, thanks.
Hi, I'm Donnell Ewart, Health and Human Services from Shasta County. And I want to thank you and the governor for your confidence in the counties, for knowing what's best for our communities. In relation to the Medi-Cal expansion, I think you call it the optional expansion in the county versus state option. I haven't heard very many parties that are very confident in the county option. I think most feel like the state option is the best idea at this point, but I know there's more dialogue that will happen with that. The state option, of course, includes the proposal to take a lot of money from 1991 health realignment to, since the counties wouldn't have the same responsibility for indigent health care. And I just wanted to point out something you probably know, and that's that 1991 realignment has performed quite well for social services. They're at, I think, the highest amount they've ever received after the growth from last year. Whereas on the mental health and public health sides, the funding levels are around 2001, 2002 levels. So we're more than 10 years behind now. And so I wanted to just challenge you to think about possibly making a reinvestment in public health and mental health with the savings that is going to happen from that Medi-Cal expansion, because it's 100% paid for by the feds for the first 3 years. So there's really no state cost there either. So it's a savings. And if it's taken back by the state, it's going to go in a general fund for who knows what. Why not reinvest that money in public health and mental health and allow the counties to decide what to do with that, at least for the first 3 years? And then I think counties acknowledge that after that, when there is a state match, that you would take some of the money to use for the match. But I think in the same spirit of giving the counties opportunity to make those decisions, I think it would be a great vote of confidence for the state to allow us to use that savings. And again, not at a cost to the state, because it isn't costing the state anything for the expansion. For us to build on what we have now, and we've suffered many cuts, and we've lost a lot of realignment, and our programs have been really cut back, and we could reinvest in that. We could build those back up to a reasonable place. So I just wanted to challenge you, and I'd be interested in any comments you have on that.
I appreciate that, and that is one of the reasons we put the mental health funding in 2011 realignment. And with CCI, I think you will see the growth for mental health increase significantly. But you are not the first person to make those suggestions. You probably won't be the last person to make them, and we do take it seriously. Because I think you make a good point about the counties knowing and having the responsibility. So we do take it seriously. So thank you very much, and have a fun time in Sacramento.